myself, Professor Kameswara, respected seniors and dear friends. Being a nice CME on Empagliflozin and its FDCs for the management of the type 2 diabetes and focus on the Indian context. See, we all see treating the type 2 diabetes, and whenever you see a type 2 diabetes, it is not only a metabolic disorder, it is a cardiorenal disease. Because in advanced type 2 diabetes, you will have the metabolic abnormalities like hyperglycemia, which is a chronic, and high index of insulin resistance, obesity, dyslipidemia, fatty liver, NASH, etc. So these are all part and parcel of your metabolic syndrome. So whenever you see a case of the type 2 diabetes in the adults in advanced stage, so you are dealing a case of the insulin resistance, which is the root cause for your metabolic syndrome. Metabolic syndrome is nothing but a cluster of the 4 diseases or the 5 diseases. They are diabetes, hypertension, dyslipidemia, obesity, and fatty liver. And coming to the cardiology, and whenever you see a case of the type 2 diabetes means you are dealing a cardiovascular disease, because the commonest cause of the death in diabetes is a myocardial infarction. So in all the diabetics, when you are dealing with the cardiovascular medicine, you should see whether the diabetic is an hypertensive or not, because it's a deadly DO, very common combination, diabetes and hypertension, because of the similar environmental factors. And there will be atherosclerosis, maybe a single vessel disease, double vessel disease, or the triple vessel disease, and that there is a heart failure. So one of the important causes of the heart failure in India is uncontrolled diabetes, maybe uncontrolled diabetes or cardiomyopathy because of the diabetes. And as far as the renal is concerned, again, the important cause for the CKD in India is diabetes plus hypertension. Unfortunately, both are very common. And there will be albuminuria. So this also you should give a lot of respect to the albuminuria in a diabetic individual. All these years we thought that renal disease means only elevation of the creatinine levels. Along with the elevation of the creatinine levels, we should give the importance to the proteinuria also. But of course, the normal proteinuria is up to the 30. When it is more than the 30 to 300, you consider as the microalbuminuria. When it is more than the 300, is the macroalbuminuria, etc. But definitely more and more albuminuria. So in a due course, so definitely that will cause elevation of the creatinine. And electrolyte imbalance is very common in the diabetic individuals, both hyponatremia and hyperkalemia. So lot of the diabetics and hypertension we prescribe ARBs. ARBs tend to cause hyperkalemia unless you check the potassium levels and if you try to increase the doses of these ARBs, definitely these will cause cardiac arrhythmias, cardiac deaths. And low hemoglobin is nothing but anemia. It's very common in diabetic kidney disease. So whatever the terms of the iron you give it, it is very difficult to elevate your hemoglobin except you start using erythropoietin. So these are the different stages of the type 2 diabetes. So when you are dealing with type 2 diabetes means you need to answer the metabolic causes, you need to answer the cardiovascular and also the renal. See, this is the natural progression of the type 2 diabetes. So type 2 diabetes is a dynamic, a progressive and aggressive disease in some of the individuals. See, if you concentrate on the insulin resistance here, the insulin resistance will go up and it definitely increases as days goes on. But if you see the beta cell function, gradual decline in the beta cell function will be there. So in the early days, even though the people are having the insulin resistance, the beta cells also produce more and more insulin. So that will take care of the hyper insulin resistance. But a day will come where your hyperinsulinemia may not reach the may not counterfeit your insulin resistance. Then a stage of hyperglycemia will start coming. So then you will have the postprandial glucose and then you have the fasting glucose also will be going on. So if you see the down, you have the microvascular complications, macrovascular complications. All the microvascular complications are directly proportional to the duration of the diabetes. Suppose if the person gets the diabetes today, so they may not get the microvascular complications, especially in the presence of the type 1 diabetes. But whereas the macrovascular complications starts much earlier to the microvascular complications. So that is the reason if you want to control the diabetic complications, you need to understand the macrovascular risk factors of any person. I mean to say a myocardial infarction or CVA, the 5 main reasons to cause these vascular diseases are diabetes, hypertension, dyslipidemia, obesity, and smoking. So in all the diabetic individual, you need to ask them to stop smoking if they are the smokers and reduce the body weight if they are overweight or the obesity and reduce the cholesterol. There is any dyslipidemia. Even though there is no dyslipidemia, there is no wrong in using the rosuvastatin 10 mg or the atorvastatin 20 mg in all the diabetes because they have the pleiotropic effects. And even though they are having a mild hypertension, maybe 130 by 85 or 1 by 90, always better to use an ARB like your telmisartan or telmisartan because they reduce the RAS blockade that gives a more vascular protection, renal protection, and cardio protection. And of course, diabetes management, you have to treat with the different OHS, and if needed, insulin also to control the blood pressure very effectively. So the treatment of the type 2 diabetes is fundamentally concerned with optimizing the glycemic control. So reach your glycemic targets, whether the fasting is around 100, postprandial around 150, and the HbA1c around 6.5, and facilitating the weight control. So the weight, the person is overweight or obese. So definitely a role of the medical nutrition therapy. So the dietary restrictions, exercise, yoga, meditation to reduce it. And nowadays we also have the good molecules to reduce the weight in the form of your antiro, tirzepatide. So that can be used when the BMI is more than the 28 or the 30 with a lot of the comorbidities. And managing the severity, so you have to treat the diabetes, you have to treat the hypertension, you have to treat the obesity, and you have to treat the cholesterol, etc. That way, we can reduce the cardiovascular risk. See, type 2 diabetes means reduce life expectancy significantly. It's not true in all the individuals. I have seen few patients, type 2 diabetes means they are living longer. No type 2 diabetes means they are living earlier. They are dying earlier because having known that they have the type 2 diabetes, so their diet restrictions, they are very compliant with exercise, they are compliant with the yoga, they are compliant with the meditation, they are compliant with the doctor's visits, they are good in taking your OHS or the ARBs or the aspirin or the statins, etc. And so that their vessels are very good, their sugars are under control, their blood pressure is under control, their weight is under control, and they are living long. On the other hand, in some individuals, having they are not diabetic and hypertensive, but dying prematurely because of uncontrolled lipids, because of uncontrolled body weight, maybe because of a lot of the stress and the strain, maybe because of the sleep disturbances, or sometimes maybe because of the genes. So that is. So here, actually, if you see the totality, more case of the type 2 diabetes, they die early because they have the early CKD, they have the myocardial infarction or cardiovascular diseases, definitely they reduces the lifespan. See, if you see the type 2 diabetes means there is a less of the 6 years lifespan. If they are also having the CKD, maybe 10 years, around 10 years. If they have the myocardial infarction, maybe around the 11 years. See, it is not true in all the cases. So most important is the increase in the life expectancy. Not only the life expectancy, we have to increase the health expectancy. So we have the two things. One is the lifespan, the second one the health span. So lifespan means just counting your date of birth, maybe 90 plus or 95 plus, even on the bed. But what is the health span? Health span means you are living very in a good spirits, and that is more important for any person having the more health span rather than the lifespan. So the good quality of the life is very important. That can be done with the good positive mind and also with a lot of the OHS or the good insulins or other things. So what is the scenario of the diabetes in India? So it starts at an younger age group in India. You all agree with me that even at the 15 years, 17 years, 18 years, we are seeing type 2 diabetes because of the childhood obesity with a lot of acanthosis, nigricans, and the skin tags, abdominal adiposity may be caused. And then Indians have the low beta cell mass and high insulin resistance. So if you see the insulin resistance, we are having the much more insulin resistance compared to the Western population. That is the reason for a given BMI, we are having the more fat, maybe 30%, 40%, 50% of fat when compared to the Western population, who are having maybe 20 or 24% of the fat. Only 36% of the Indians achieve the good glycemic control. If you see the HbA1c, so nearly 74% of our population are having HbA1c beyond 9.3. So that indicates that a lot of the people in India living with the type 2 diabetes with a very high BMI. Micro and macro cell complications appear early in the Indians because we are getting the diabetes in younger age group. So even after the getting the type diabetes, maybe after the 5 years or the 10 years or 15 years, we are bound to get the complications. So that is the reason we are getting the complications much early. So not only complications much early, even at the time of the diagnosis itself, we are seeing a lot of the complications. That means in India, 40% of the type 2 diabetes, they present with the complications at the time of the diagnosis itself. Today, just half an hour back, I have seen one patient referred by Dr. Sriram of Naina Hospital. So she approached ophthalmologist for the loss of the vision in the right eye. So when he examined, he had proliferative diabetic retinopathy and severe macular edema and complete retinal vein occlusion. And he asked a leading question. So his diagnosis is proliferative diabetic retinopathy. He asked a leading question to that person, what is the duration of the diabetes in you? No, sir, I am not having any diabetes. The sister checked the blood sugar, it is 550. So what it means? It means that she is a diabetic for quite a long period without noticing it till she got the vision loss. This vision loss is because of the proliferative diabetic retinopathy. This is because of the uncontrolled diabetes. And he referred to me and he started a digital therapy that came back to me. See, that type of that means a lot of the people, the same thing happens to your foot ulcers also. For amputation, first time amputated in the hospital, diagnosed as a chronic ulcer, non-healing because of the diabetes. He didn't know that he is living with the diabetes at all. So that is very common. Sometimes in the ICUs, cardiac ICU, one drug is common for all the people is the insulin. Because all the uncontrolled diabetic individuals will be having unstable angina or acute coronary syndrome admitted in the ICUs. So this is very, very important. So early identification of the diabetes, early initiation of your medical nutrition therapy, early initiation of your metformin, early initiation of your SGLT inhibitors, early initiation of your gliptins make a wonders for a lot of our diabetic individuals to avoid the complications at an early time. See, 1 in 3 patients with diabetes will have early onset of the cardiovascular disease. Obviously, I am telling all the vascular risk factors, they are all very much there in our society. So obviously, diabetes means cardiovascular disease. See, CAD accounts for more than 80% of all the deaths. I told you the commonest cause of the death in diabetes is myocardial infarction. See, this is the profile of the clinically diagnosed type 2 diabetes among the Asian Indians. You see the highlight HbA1c how much? 9.1, clinically diagnosed. So no diabetes. Diagnosed during the screening. So whenever you have a camp, diabetic screening camp, so there it is about 8.3 plus or minus 2.4. That means, so the lot of the people, whether they're diagnosed earlier or diagnosed during the screening, so they're living with HbA1c beyond the 9 or the 9.5. So Indians present with the high levels of HbA1c, whether they're diagnosed clinically or during the screening. So what is the unmet needs of the Indian patient? So address the multiple pathophysiology in the combination. You know the omnia software or the dirty doesn't cause the diabetes. So whenever you give a prescription, you please address these pathophysiological mechanisms and additional treatments that provide both glycemic and non-glycemic benefits. So that is the reason we say diabetes management means A, B, C, D. A stands for your A1C control, B stands for your BP control, C stands for your cholesterol control, D stands for your diet, your drugs, your doctor's appointments and your compliance, and E stands for your exercise program. So unless you consider all these A, B, C, E in a diabetic individual, if you address only diabetes and you left B, C, D, E, definitely the people will get early attacks. Control of the diabetes comorbidity is suboptimal in most of patients. So in a diabetic individual, we give a lot of respect to the OTs rather than the ASL. What I mean to say, when a diabetic individual gets the acute coronary syndrome, he always thinks of cardiovascular medications only. So he neglects the diabetic medications. The same thing happens to when he gets any complication. So that comorbidities or the complications has to be addressed very effectively along with your diabetes. So don't use the certain drugs in the OHS when the creatinine is going up. Reducing the occurrence of the hypoglycemia, the weight gain as recurrent distressing side effects. See, all these years, the common side effects of the diabetes management is hypoglycemia and the weight gain. So these two are very much interested because a glycemic variability and the ideal body weight. These two are very important. That is the reason. So nowadays we concentrate more on the pentad rather than the triad. So the triad means control your fasting, postprandial and HbA1c. Pentad means glycemic variability and also the quality of the life. So you have to add the glycemic variability and quality of the life in all the diabetic individuals. So if you concentrate on the glycemic variability, obviously we avoid both hyperglycemia and hypoglycemia. Improve the patient compliance with the better oral medications. This is a very important. Every drug will have a few side effects. So you concentrate on these side effect profiles, and some drugs will have the contraindications to be used. So you understand all these things so that definitely the compliance will be very good if you address these things. So early intensification is a very important. A combination drug therapy is the rule nowadays and reduce the occurrence of hypo and weight gain and glycemic and cardiorenal benefits. So these are all very important. And oral option improving the patient compliance, but that doesn't mean that when the patient needs a basal therapy or an intense insulin therapy, one has to be addressed very aggressively, because when the patient presents with the glucose toxicity, say when the fasting blood sugar is above 300, postprandial above 400, which HbA1c is around 14 or the 15. So there is no meaning in initiating in the oral therapy in them even on the day one of the diagnosis. So for even on the day one of the diagnosis with very high blood sugars, so there is always a role for your insulin therapy. So oral therapy, okay, but insulin therapy is also okay even on the day one in certain individuals. So early intensification of the cardiorenal protection and the minimal side effects is always needed. So what the guideline recommends? So you are aware of this slide. So nowadays, no, the treatment is not glucocentric, but it is individualized. So whenever a diabetic is sitting before you, you see whether the patient, whether the fellow is at the risk of atherosclerotic cardiovascular disease, or at the risk of heart failure, or at the risk of CKD, or at the risk of hypoglycemia, or the weight gain, etc. And then treat the choose the drugs accordingly. So of course, your lifestyle methods are very important in all the individuals, and metformin is also important in certain individuals. But the drug of the choice in these conditions is when the fellow is at risk of atherosclerotic cardiovascular disease. That means when the fellow is overweight, with a strong family history, with the smoking, etc. Choose these two drugs, either GLP-1 receptor agonists or the SGLT2 inhibitors. So when the fellow can afford, so definitely GLP-1 receptor agonists are very good drugs. They are the parental ones, maybe one shot a week, and SGLT inhibitors, oral drugs, every day you have to use it. When the fellow is at risk of the heart failure, so definitely there are the three reasons to cause the heart failure in our Indian population. One is ischemic heart disease, the two is diabetes, and third one is the hypertension. So there, SGLT inhibitors are very important drugs to be used in all the heart failure population. So if you have the four pillars in the management of the heart failure, and one pillar is the SGLT inhibitor, even though the fellow is a non-diabetic. So in a diabetic with heart failure, so there is a compelling indication to use the SGLT inhibitors. When the fellow is at risk of the CKD, so definitely again SGLT inhibitors are cardioprotective drugs. So you have to use renoprotective drugs. We have to use them because the CKD people, they die in the hands of the cardiologist rather than in the hands of the nephrologist. So in all the CKD individuals, you see that this fellow will be having both renoprotection as well as the cardioprotection. So both the reno and the cardioprotection can be seen with your SGLT inhibitor therapies. When the weight is a very big problem, when the fellow is overweight or obese, so now you have the injectable GLP-1 receptor agonists like Wegovy, that is the injectable semaglutide once in a week, or a tirzepatide, that is both GLP-1 and GIP agonist. So your Manjaro. So these two drugs are very useful to reduce the body weight in these individuals. So the focus on the patient-centric approach. So definitely the GLP-1 receptors and SGLT inhibitors are very preferable in India. And sulfonylureas, now we are not using the sulfonylureas much early in our affordable patients for the fear of your hypoglycemia. But when the HbA1c is beyond your 8 or the 9 or the 10, so definitely in our people there is a role of the sulfonylurea in them. But don't poke the sulfonylurea for a longer period because there will be the second sulfonylurea failure. So in the initial days of the sulfonylurea therapy, the response is so good. But after a few years of your sulfonylurea therapy, continuous sulfonylurea therapy, the blood sugars keep going in. So there you have to identify whether there is a possibility of the second sulfonylurea failure then stop using the sulfonylureas and then use other drugs. So this happens only in the people those who cannot afford the uh, uh, these drugs, SGLT inhibitors or GLP-1 receptor agonists. So this is the American Association of the Clinical Endocrinology. See also same thing. So when the fellow is overweight or the obesity, the preferred drug is GLP-1 receptor agonists or the SGLT inhibitors. And alternative, you can use the gliptins. When you are at risk of the hypoglycemia, so when the fellow is at the risk of the hypoglycemia, so definitely the drugs to be avoided are the sulfonylureas and the insulin, because these two are the potent hypoglycemic agents. So the preferable drugs are either the GLP-1 receptor agonists or the SGLT inhibitors and the gliptins. When the cost is a big factor, nowadays these all drugs are available and I think they are all affordable right now. So earlier SGLT inhibitor therapy means maybe 70 rupees or 50 rupees. And the gliptins are about 80 or 100 rupees. Now they are available around 10 rupees. I don't think that cost is a big factor right now. Severe hypoglycemia, hyperglycemia. So definitely when the fellow is symptomatic, hyperglycemia, so there is always a role of the insulin therapy. So in all the symptomatic diabetic individuals, when the fellow is the catabolism, so don't use the OHS. So simply start the insulin therapy. Once the fellow is asymptomatic, then you come back to the OHS. So whenever you see the cardiovascular disease, any cardiac patient, you just rule out the diabetes mellitus. In the same way, all the diabetic individuals, you rule out the cardiovascular disease and the chronic kidney disease. These are the fundamentals for any physician or any clinician. Suppose in the cardiovascular case, you diagnose that type 2 diabetes is also confirmed, then you think of the two things, whether the fellow is at risk of atherosclerotic cardiovascular disease or the heart failure. So as far as the cardiovascular disease means, two diseases. One is your coronary disease, the second one is heart failure, your muscle disease. So in those three conditions, you can use either the GLP-1 receptor agonist or the SGLT inhibitors. When the fellow is at risk of heart failure, then the SGLT inhibitors are the drugs of the choice. You have to use them along with your RNI, along with your cardioprotective beta blockers, and also with your mineral receptor antagonists like spironolactone and phenylalanine. So when the fellow is at risk of the CKD, so definitely SGLT inhibitors are useful. And now the phenylalanine, this is a steroid-sparing mineral cannabinoid receptor antagonist, is available at the doses of 10 mg and the 20 mg. And according to GFR, you can use 20 mg when it is more than the 25, or when the GFR is less than the 25, you can use the 10 milligrams. Very good drugs, very useful drugs. So these are the class 1 and the level A recommendations to use the SGLT inhibitors in all the heart failure ref. So heart failure is divided into 3 groups with the ref, PEF and mid-range. So in all these 3 conditions, so SGLT inhibitors are very useful drugs. So the initial combination therapy, so 90% of our diabetics, they need the combination therapy because our HbA1c levels are beyond 1.5 to above your target. So your target is 6.5 or the 6. So when the HbA1c is beyond 7.5 or the 8, so definitely there is a role of the combination therapy. So SGLT inhibitors, the class benefit beyond the glycemic control, you have the cardioprotective effects like the decreased rates of the myocardial infarction, strokes and CV deaths, lower risk of the heart failures and hospitalizations, lower risk of the fatal arrhythmias. So these SGLT inhibitors are very useful in these conditions. And renoprotective, they reduce the glomerular pressure, they reduce the albuminuria, they improve the GFRs, they improve the renal tubular function, and then they reduce the CKD progression. And pleiotropic effects, so you have the weight reduction, you have the improves the HDL levels, and they reduce the uric acid levels. So with this cardioprotection, renoprotection, pleiotropic effects, and SGLT inhibitors, undoubtedly they are very good drugs to be used in all the people with atherosclerotic cardiovascular disease, CKD and heart failure. So they have the diuretics, they have the glucose excretion, that is the glucosuria. So they call therapeutic glucosuria. So the people on the SGLT inhibitor therapy, the urine sugar will be 3+ and the 4+. That means the drug is working. And they are also having the natriuresis. Along with the glucose, they pass a lot of the sodium also. So the intermediate effects, the myocardial sodium content will be inhibition of this. And there is inflammation, the oxidative stress, fibrosis also will be reduced. Intraglomerular pressure reduction, LV wall stress and LV mass reduction. And there will be the preload reduction, the afterload reduction because of the improved vascular function of the decreased interstitial volume. So all these things, they reduce the blood pressure, they reduce the body weight, they reduce the A1C, that is diabetes management. So finally, they reduce the CV events and also the renal events. So whatever the dosage of this EMPA and the DAPA. So we use EMPA in the form of 10 and the 25 or the DAPA 5 and the 10. So if you see the A1C reductions with the 5 mg, the 10 mg of the EMPA 0.6, whereas the DAPA 5 milligrams is a 0.6 and the EMPA 25 0.7 and the DAPA 10 mg is the 0.7. So that means that a comparable reduction in the levels of HbA1c either with the empagliflozin or the dapagliflozin. And the body weight, so again the different drugs are there. All those of the DAPA and EMPA and the CANA statistically reduce the body weight versus the placebo. So nowadays we are not using the canagliflozin for the fear of your peripheral vascular disease or the Horner's gangrene, etc. But EMPA and the dapagliflozin are very popular in the Indian market. See, SGLT inhibitors, they reduce the heart failure events and the CV death. And these effects appear constant in the patients with the varying combination of these diseases. See the heart failure people, heart failure without CKD, heart failure without diabetes, heart failure with CKD, heart failure with diabetes, and then all the three, heart failure, diabetes, and CKD. So any aspects, there is always a role of the SGLT inhibitors to use in all these cases to reduce the incidence of the heart failure, to reduce the hospitalization of the heart failure, to improve the quality of the population. So the consistent reductions in the CV, the heart failure, and the kidney outcomes. If you see the EMPA outcome study with the empagliflozin, the CANVAS program with the canagliflozin, the declared TB with the dapagliflozin. So if you see here, so the endpoints, the primary outcomes, reduction will be seen good with the empagliflozin, CV death, heart failure admissions, and also the kidney outcomes. So it is a oral tablet, a competitive inhibitor of sodium glucose co-transporter 2. So it's situated in the proximal convoluted tubule. Part of the glucose is filtered to the glomerulus that will be reabsorbed into the proximal convoluted tubule. That reabsorption will be blocked by using these sodium glucose co-transporter 2 inhibitors like EMPA, the DAPA, and also with the anti-hyperglycemic activity. Here the highest selectivity for SGLT2 over the SGLT1 and cardioprotective and the renoprotective effects, largely independent of the glycemic control in patients with type 2 diabetes and established cardiovascular disease. So indications, so already I told you that indications in all the type 2 diabetes at high risk, at the risk of getting atherosclerotic cardiovascular disease or heart failure or the CKD. So what are the clinical evidence? See, this is the EMPA outcome trial. So empagliflozin in addition to the standard care, they reduce the CV risk and improve the overall survival in adults with the type 2 diabetes at high CV risk. See, there is about 14% reduction in the MACE, 38% reduction in the CV death, 32% reduction in the all-cause mortality, and 35% reduction in the heart failure hospitalizations. So the overall safety profile of EMPA was consistent in the previous clinical trials and the current information. So they improved survival rates. They reduced the EMPA reduced study. That means they studied in heart failure with reduced ejection fraction in rough population with the EF is less than the 40 here, nearly 3,730 patients. See, there is a risk reduction by about 25% in using this empagliflozin. Again, lowers the risk of the serious kidney events in the rough individuals to the tune of about 50%. They also studied the preserved ejection fraction when the ejection fraction is more than the 40 or more than the 50 in nearly the 6,000 patients. In both the mid-range and also in the preserved, so the CV death or hospitalization for the heart failure is also reduced. It also reduces the stress blood volume in patients with the rough individuals. Blood volume changes, so reduces the preload, reduces the afterload. EMPA kidney design. Here there is about 6,000 patients. 6,000 plus patients, the CKD, the established CKD, at risk of progression with the GFR somewhere between 20 to 44 or 45 to 90, with urinary albumin creatinine ratio more than 200 in about 8 countries. So there they used the empagliflozin 10 milligrams once a day. And primary composite outcomes are either CV deaths or the kidney disease progression. So the results are here. So the progression of the kidney disease or the death from the serious causes occurred in 432 of 3,000 patients, that is 13.1% in EMPA group, whereas about 16.9% in the placebo group. Clearly shows that the advantage of the empagliflozin in these individuals. So at 2 years, EMPA reduced the incidence of the ESKD, so end-stage kidney diseases. The incidence of a sustained decline in the GFR to less than the 10, and the incidence of a sustained decrease in the eGFR more than the 40%. So in study conclusion, at risk for the disease progression, including a large number of the patients without the diabetes, with a GFR of less than 30, so empagliflozin led to a lower risk of progression of the kidney disease or a death from the CV causes. So it reduces the relative need for the insulin also by 54% versus the placebo. They reduce the relative need for more than 20% of the insulin. So whatever the EMPA with the metformin combination. So it's a very good combination. See in the kidney, there will be the decreased glucose and sodium reabsorption. So because the more and more glucose excretion, and sodium is also excreted to the distal tubule, and there will be the polyuria, nocturia, etc. So reduce the pill burden, simplify the dose regimen, and adherence to the therapy. So ultimately lead to the enhanced glycemic control in the type 2 diabetic individuals. So it's a complementary mechanism of the action between the empagliflozin and the metformin. See, the metformin acts at the level of the insulin resistance. So it acts at the level of the liver, muscle, and adipose tissue, whereas the empagliflozin totally acts at the level of the kidneys. So initial combination of the EMPA with the metformin in patients with the type 2 diabetes. So you can start with the EMPA 12.5 milligrams BD and the metformin 500 mg BD. Now it's the combination is available, EMPA plus metformin, and EMPA 5 milligrams and the metformin 1000. We are not using it. So we are using either the 10 milligrams or the 12.5 milligrams or the 25 milligrams. So in conclusion, the initial combination of the EMPA and metformin could represent a valuable treatment option for the newly diagnosed patients with the type 2 diabetes. So those people who are at risk of these diseases, so definitely from the day one, you can start the metformin with the empagliflozin. So when to initiate the EMPA plus gliptin and the combinations. So one after the metformin initiation, when the sugars are very high and the A1C is very high, so you need to uptitrate the dosages. So definitely there is a good combination to use the EMPA and the gliptin combination along with your metformin. Prior to the metformin initiation in suitable patients, metformin is contraindicated for product. So some people with CKD or some people when they are having the gastrointestinal side effects, so definitely we can't use the metformin much further. So definitely we have to stop using the metformin. Then we can choose the either the SGLT inhibitors or the gliptin in the patients. Patients with the high HbA1c who fail on the metformin, so definitely we add the subdrugs along with the metformin. So this is the fixed drug combinations. They give excellent treat to target benefits to the patients. So uncontrolled the metformin plus second line. So uncontrolled the metformin with the DB4 or SGLT inhibitors. So definitely we can use these drugs. And when the fellow is on the insulin therapy, so in the type 2 diabetes, still the sugars are not under control. So when fellow is not in the hypoxic condition, so then you can add this combination of the SGLT inhibitors and the gliptins along with the insulin therapy. So based on the CV risk, including the heart failure, HbA1c criteria applied. So when you can use the SGLT inhibitors or the DB4 inhibitors. So this combination may be preferred over the other conventional therapies. So the timing range. So this is also very important. So the timing range means the blood sugar glycemic variability. So the person should not get very high blood sugars or the low blood sugar. So this is the better clinical outcomes can be seen when you keep the blood sugars in the time in range. So this is the good combination to keep the sugars time in range. So there a lot of the studies are there. So thank you very much for your patience.